Thank you all for joining us today for another episode of our podcast, Moving to Value Unscripted. My name is Dr. John Rodas, and I'm a recovering ex-hospital president and am proud to be the president of the Moving to Value Alliance. The Moving to Value Alliance, MTVA, a 501c3 nonprofit, is a multi-stakeholder grassroots organization whose purpose, put simply, is to foster a community that aims to create a value-based healthcare ecosystem with high-quality outcomes at a reasonable cost for plan sponsors and their members, beneficiaries, or employees. Our community has grown substantially over the past few years. We started in Connecticut, but now have nearly 1,000 members from more than 40 states all over the U.S., and our members include many value-based influencers. I want to thank our sponsors whose support makes this presentation possible. We'd like to give a special thanks to our trade member sponsor, Hartford Healthcare. We're joined today by my fellow board members, Lisa Trumbull and Dr. Steve Schutzer. Lisa Trumbull is the CEO of Sohn Health, Southern New England Healthcare Organization, a physician-led clinically integrated delivery system in Connecticut and Massachusetts. Dr. Steve Schutzer, a nationally renowned arthroplasty surgeon, is one of the founders of MTVA and is the co-founder and president of Upswing Health. Our special guest today is Brian Klepper. Brian is the CEO of Proven Health LLC and a nationally prominent healthcare analyst and commentator. He speaks, writes, and advises extensively on the management of clinical and financial risk, high-performance healthcare, and realizing the potential of primary care. Brian also started the Healthcare Benefits Hackers Forum in 2018, which has grown to over 1,100 members, including all of us at MTVA. We're all big fans of the Hackers Forum, and we're excited to speak with Brian today about endeavors into the retail healthcare space and why so many have failed. So, Brian, thank you so much for joining us today, and it's always a pleasure to speak to you. I always, when I talk to you, I'm always thinking I'm talking like Beyonce. You're like such a star in the healthcare reform space, and you've been at it for so long. It's an honor for us to have you here today. But Brian, why don't we just start by telling our listeners how a guy with a PhD from the University of Florida in speech, hearing, and language science ended up getting into the healthcare reform space. There's got to be a backstory there somewhere.
I needed a job. I came out and I ended up taking a job as the assistant to the executive director of a state university think tank on children's health policy. That's where I started. And then I got more and more involved in healthcare. I went from there to the Nemours Children's Clinic, which at the time had a big outpost in Jacksonville, Florida, where I was from. Then I went from there to consulting. And I sort of announced that I was an expert, and so I became one. And I began to get gigs on healthcare value and performance, basically. And that grew into a consulting practice that I had for about 13 years. And then I finally decided that the healthcare system was going to fail. And I started a national healthcare reform effort called the Center for Practical Health Reform, and had very prominent people involved with it. Harris Berman, who was the guy who founded Tufts Health Plan, George Lundberg, who at the time was the editor of JAMA, and then ultimately Medscape, people of that ilk, and did that for about 7 years, and then eventually came back out and went into the private sector. I became an owner in a worksite primary care company out of Orlando. And then one thing has led to another. And I finally ended up about 10 years ago beginning to hunt organizations that I could legitimately call very high performance organizations. I would find them, I would vet them. If they passed muster, then I'd go out into the market and I would advocate for them. And I had developed relationships with about 20 organizations that are like this. They're all knock it out of the park kinds of organizations. And in the process, I've learned a lot about how healthcare not only does work, but can work. And I think that's been the most valuable part of the experience to me. And so talking about primary care and the different manifestations that primary care has developed at this point and where it's got to be going, I think is a critical topic. Primary care is, in a sense, our most important specialty. It is the doorway into the rest of the system. and whoever controls primary care ultimately controls the system. However, it's been under attack by the rest of medicine and the commercial interests for about 25 years through an organization that's a part of the AMA called the RUC. And I've been involved in that fight, but I think there's a lot to talk about with the retail sector and primary care and how else primary care is finding its way right now.
Yeah, your writing is on the ruck and how the compensation is geared towards specialty care and not to primary care has been for those who haven't read it. Everyone should read that piece. It's very educational and I have to say, Brian, if you endorse an organization, I can tell you it's the gold seal of approval for sure. It's no one has to question it. It's really a high value provider. Steve?
Yeah, no, I just want to go back to your roots, Brian, if we could. Clearly, you've been focused on high performance. When I think of you, that's what I think about. And as John just said, you're a gold seal of approval. And we met when you were with the Validation Institute through our friend Jeff Hogan and went through CJRI, our institute, went through a really rigorous 6-month analysis. And, you know, you don't buy your way to Validation Institute, but tell me, where did you get interested in data? Because you can't assess performance without credible data.
Yeah, and that has been what I've been focused on from the time we began my consulting practice, which was in 1989, 1990. The name of the original consulting practice was Healthcare Performance. And we started going in for employers and doing a review on their health plan to say, here's what your population looks like, and here's what they're experiencing, and your health plan is or is not doing a good job based on the data that we could get. That's come a long way now, and we think that it's still an immense problem, and we think there are solutions to it, and we can touch on that, what I think can happen and should happen. But yeah, that's been an overarching passion.
Something that's bugged me for the last maybe 20 years about data. So, you know, John and I both got our education, healthcare education with Porter and Kaplan at the business school, took the course, value measurement, and we both drank that Kool-Aid. And, you know, to our credit, with John's leadership as hospital president, we were able to teach 45 orthopedic surgeons about value, and they believed it, right? But one of the challenges we've always had, Brian, is we look at the numerator, which are the outcomes. And as a surgeon, I'm thinking about the outcomes that matter to the patient for their problem, right? They don't care about length of stay. They don't really care about infection rates. They care about when they can pick up their grandchild, play golf, over the true cost of delivering those. To me, that's healthcare right there. Patient-reported outcomes over true cost of delivering those outcomes. But the question I have is, every time we get into a conversation with a purchaser, what do they focus on? The denominator. It's all about price.
Right.
And yet I'll never forget, John, you remember when we had Ruth Coleman as a guest from Health Design Plus, and one of her slides I'll never forget, that 2/3 of every dollar that was saved by going to the Mayo Clinic and COE and Walmart was on quality. 2/3 is on appropriateness, quality, readmissions, and yet everybody zeroes in
on the cost avoidance part.
Yeah.
Which is not insignificant, the cost avoidance part, but you're absolutely right. I always think that's a very important point that gets understated. I think, Steve, though, and I don't want to answer the question for Brian, but, you know, I think, and we've talked about this, you know, a million times, is that cost is a lot easier to analyze than quality. Quality is complicated. It's and like you said, even to the patient, it's a quality. For me, maybe I would care more about infection rate of Alzheimer's surgery, whereas the average person really probably, you said, cares about when can I go back to work, or when am I going to get down on my knees and play with my grandkids. So quality can be very individualized, whereas cost is dollars and cents. You know.
To your point, understanding the relationship between quality and cost is important, and most employers and most patients don't understand that. If you go to a facility that has a lower cost, but their quality is bad, and you're admitted and you have infections and you have additional follow-up procedures and stuff like that, that adds to the cost, and that's not understood. So all of a sudden, a cost that you thought was somewhat understood and fixed is no longer understood. It's exponentially more expensive. And, you know, with us in managing patients, we see this all the time where, a very reasonable procedure at a hospital should be done within a certain price range, but then they have an infection or some other situation happens, and all of a sudden it becomes a multiple and
Right.
$300,000-$400,000 case.
Right.
And that's where the quality matters the most. But unlike when you purchase a car, where people can kind of see quality ranked in a way that's understood to the average person,
Right.
it's really really opaque to the average person when it comes to healthcare.
Yeah, not even the average person, Lisa. I think it's opaque, frankly, to a lot of healthcare providers. I'm not sure,
Yeah,
and I
you're
think
right
I
about
want to
that.
I want to delve into this with Brian regarding primary care, because obviously, hundreds of millions, if not billions of dollars being dumped into this space. And because, not all even primary care folks know, can I get a drug cheaper, or can patients get their drug at an outpatient infusion center versus a hospital? I think we as physicians aren't really taught much about the variability in cost, to be frank. So Brian, let me just jump into what our theme for today was. There's been zillions of dollars in the merger and acquisition space, and specifically the big retailers trying to get into the primary care space and the healthcare space in general. Of course, CVS, Aetna, Oak Street, Signify, that's all one part, and Walgreens, of course, now with Village MD and Summit Health, and Amazon and One Medical, Iora, and go on and on. Walmart, virtual care. Who else? Best Buy is even in the space. I mean, it seems like everybody is getting in the healthcare space, and big numbers. And we're talking about almost $4.5 trillion now spent, and we've acknowledged, and they get it. There's a tremendous amount of variability here. Tell me why so many have not been successful. These folks have been very successful retailers in every other space. They get into healthcare, and we can go Berkshire Hathaway and on and on. People that are legitimately great companies have failed. Tell us, your thoughts on why.
Well, I think that the key is that to be economically viable, primary care has to be tied into the rest of the healthcare economy that's downstream of it. And it has to be to some degree accountable and responsible for helping to manage that downstream component. For the retailers, all of them have set it up to be really what we used to call convenience care. They're doing minor or trivial illnesses and injuries. They're doing a lot of hand-holding, but they're not doing life management care. And they are not fundamentally managing the risk that is associated with healthcare. I mean, when I'm having a discussion with the kind of people who are on this call, I can say healthcare is really about clinical and financial risk. And if you don't get that, you're at sea. So Walmart spent its first 10 years of Walmart Health with a team that was building small clinics, primary care clinics, and they were putting them in the back of their stores so that people would go to the back and they'd get some diapers while they were there. So it was a loss leader, and everybody knew that, you need to have shots or whatever now and then, but it wasn't really what we think of as true primary care. And I think it's an important distinction. Primary care folks should be focused on three things. There's prevention, there's minor acute care, and then there's the big one, which is chronic disease management. And chronic disease management eats up 75-80% of all US spending. And it's all focused in about 13 major diseases. And most of those diseases are cardiometabolic. And the substrate for that is, of course, blood pressure. If you go to the CDC and you say, how are we doing on blood pressure? What we'll find out is that 44% of American adults who have high blood pressure have it under control. Control is the metric of interest here. And it says, here's what percentage of the population, if you test them today, their numbers are within acceptable limits or not. So 56% of American adults with high blood pressure, they're out of control. So that's the tip-off. 10% of American diabetics are under control. 1% of Americans with heart failure are under control. And the reason for that is that nobody in primary care is measuring what their control rates are for primary care for these chronic diseases. How lame is that?
Right, but let me interrupt you for a minute. It's actually, to be fair, it's a little worse than that, because you're only talking about patients with known hypertension who are under the care of a doctor. And
That's right.
patients with known diabetes, I just want to remind our listeners that a significant percentage, of about 25 to 30% of patients with diabetes don't know they have it, have not been diagnosed, and the same for hypertension. So it's even far worse than that. It's an embarrassment.
Well, and most patients haven't seen a primary care either, John, right?
Right.
Our country has this fear of the old gatekeeper methodology. So if you say to them they have to have a primary care, the first thing everybody does is reacts to what I'm going to not get because I'm going to see a primary care. So there's a lot of self-referral and uncoordinated care that's happening here.
Right.
So they're getting other things treated by specialists and the like, or going to the ED or the urgent care,
Right.
but are not getting their entire health looked at because they're not visiting a primary care
Well,
provider.
Like my
And
mother told me when I was going to go to an annual visit, my first annual visit, she said, "Why are you going?" I said, "Well, I figured that I should have an annual visit. You know, I'm a doctor." She said, "Don't go." I said, "Why not?" She goes, "They always find something."
Yeah.
I think that probably reflects the average American. But you're
You know,
right,
but
Lisa. I think between 20 and 50 years old, certainly for men, most of us don't have ever seen a primary care physician. And women, if you exclude OBGYN providers, you're right. If you don't count them as primary care, and I would say mostly they haven't been primary care. I think OBGYN has pivoted a little bit to provide some primary care. Let's go back
can
to
I
your comment, Brian, because I think touches on Steve's point about metrics and data. You know, to be fair, Steve's orthopedic surgeons, if I asked them, "Hey, what's your infection rate?" they could tell me the number. They knew the number. But I think if you ask the average orthopedic surgeon or the average OBGYN for
Right.
that matter, what's your infection rate with cesarean section, they would only say, they would give you the numbers that are in the textbook. They actually wouldn't know their own numbers. So we shouldn't be shocked that people don't know it. But it's what's surprising today is that with an electronic medical records where the data should be at their fingertips, it's still not. So why isn't it, Brian? Because is it the incentives that just malaligned? We haven't emphasized this as much. What's your thinking on that?
The incentives have not been aligned for a long time. Back to the RUC. The RUC is a secretive AMA committee. It stands for the Resource-Based Relative Value Scale. That's a financial mechanism that was developed, a stupid financial mechanism that was developed by a Harvard professor, in which the individual groups of specialists by specialty determine what the value of every procedure is. So the guys who are doing the work provide estimates of what a given procedure should be paid at. And that process was dominated by specialists. There were 31 doctors. There were 26 of them who were specialists, 5 of them primary care. So the primary care guys always got outvoted. And the goal was to get around the primary care guys and get patients to the more lucrative services that were downstream in the specialties. That system of payment was adopted by Medicare, and then the commercial organizations began to use it. And it has made primary care undesirable as a profession, but it also colored everything. So if you remember in the late 80s, early 90s, early days of managed care, health plans began coming out with plans that said, oh, you don't need to go to the primary care doc. If you want to go to the specialist, you just go right to the specialist. And when that happened, there was a concomitant explosion in unnecessary care, and costs began to explode genuinely at that time. So there's a lot of history here. An interesting phenomenon that happened at the same time was that large corporations began to think about putting in their own primary care clinics on site. And when that happened, if you think about what it really was, the entire health system was fee for service. There was rampant overutilization and overpricing. And what the vendors were offering in the on-site clinic community was a fixed price to take care of your population and a value prop that you'll get it back and more in lower cost and lower utilization services downstream with better outcomes. And that was where the clinic movement began. And it has not lived up to that, but that's where it started. Right after that, the primary care docs began to get picked up by the health systems. and put in as referral mechanisms into the health system themselves to drive utilization. And that's been a dominant play since then. Now we're getting interested in primary care organizations that can genuinely manage full continuum risk in collaboration with high performing specialists. And I think we're going to see a lot more of that. But the efforts by the retailers to win in this space, they just couldn't make the numbers work. The costs of running a primary care organization without the benefit of getting part of the impact that they were creating in the 90% of healthcare dollars. Without access to that, they couldn't succeed over time.
Yeah. Brian, I think that's an important point to the retail question that we got earlier, that, a lot of these corporations that have made efforts or tried to make headway in healthcare, I think there's a general oversimplification in their minds of the economic model. And also, I think a lot of them had it, as you said, as loss leaders or as a way to get in. Maybe I just want to, make my margin on the Medicare business. I want to carve apart the business, right? So most of the motivation was profit motivation and not necessarily for the original purpose in terms of why medicine and primary care exist, which is to improve the health outcomes of the people they serve. And so their business model was upside down, similar to hospitals, right? I've been in a number of hospital systems where hospitals acquire primary care. They strip out all the ancillaries. They put them in a big medical group. They allocate all this overhead and cost to them. And then they tell them, keep, generating work RVUs, see more patients. And then they complain that there's a loss on the bottom line to having a primary care practice, right? Because they just took all the economic value out and they're not looking at all the other economic value that could occur. So don't you think that the primary issue that we're all dealing with is the misalignment of incentives and the fact that the incentives create greed on the economics, and those motivations don't comport with trying to improve quality in healthcare and the outcomes of the individuals that are being served?
I think you're absolutely right, Lisa. If you want to see in a single nugget what is going on, look at the fact this week there was an announcement that Humana is acquiring the leases of 23 of Walmart's clinics that they're closing down to use them for their Medicare Advantage population, because they can then manage the risk for those populations through those clinics. And those are two sides of the same coin. Humana knows what it's doing here. And it said, ready-made clinics, ready to go. And they will use it to manage the risk, and that's where they'll make their money. So it's clear that primary care has an important role once you start managing in risk-based populations. And Medicare and Medicaid will be first. But the value for commercial populations is enormous as well.
Yeah.
And it just hasn't been used very well.
Yeah, I agree. I think that one other point to make on this is, I think, and I wonder if you believe this too, in the short run, having primary care exclusively is a benefit, particularly when you're looking at a Medicare or Medicaid population. But after you've gotten to the point, if you're truly managing the population, you've managed the population for a number of years, and the quote unquote low-hanging fruit has been addressed, right? You then need your specialists. And you need the specialist in the way that Steve's group works. Yeah, looking at cost and looking at the quality components in order to really address the other pieces of the expense in healthcare that occurs with uncoordinated care, or quite frankly, poor specialty care.
Yeah, no, that is absolutely true. I mean, ideally, you're looking for high-performing primary care, and then you're looking to integrate that with high-performing specialty services. And the definition of a high-performing specialty service, and I think Upswing would be a good example of this, is an organization that consistently delivers measurably better health outcomes and or lower costs than conventional approaches, and particularly in high-value niches where the money is. So we're not talking about wellness, for example. We're talking about musculoskeletal care. We're talking about chronic disease management, maternity, surgery, drug spend, the big ticket items, and focusing on them. And one of the mistakes, in my opinion, that a lot of American healthcare has made is they say, oh, we need an orthopod. So there's an orthopod in our neighborhood. We'll go get him. Rather than going and finding groups of orthopedists who've developed a new paradigm in how to manage cases, and they've got the data to show that it delivers consistently better results. And work with those people and then scale the living daylights out of the model. And I think that when we start to do that, we will reap much lower costs and much better health outcomes. And we're going to be headed in that direction. But we've got to be discriminating about who's doing a really great job and who's not. The things that I have uncovered in the work that I do, I'm very easily entertained. So when I discover something that is fresh and great, I'm very enchanted by them. So for example, there's a company called Sera Prognostics. Sera Prognostics has a proteomic test, a blood-based, protein-based test that is administered to pregnant women in week 18. And it will accurately identify 88% of the women who will deliver preterm babies. Well, if you know you're going to have a preterm birth, you call in a maternal and fetal medicine physician or a high-risk OB, and you get that clinician to lengthen the gestational period. And if you can get a week or even 2 weeks out further, you get profound improvements in the quality of that life and the cost of that life for that individual's entire lifetime. How is that not an incredible win? Or the company has now sold, but there was an AI company that was focused on chronic disease and guiding physician prescribing for patients with chronic disease. So it was precision medicine for primary care and chronic disease. As I mentioned before, 44% of Americans with high blood pressure have it under control. In the pilots that this group did using the tool that they developed, they got control for hypertension to 94% consistent. That one thing alone would drive total healthcare spend in the US down by something on the order of 20%. The work that's going on now in pharmacogenetics. So pharmacogenetic testing provides a genomic profile of the patient, and it tells the doctor what drugs that patient can and cannot metabolize. So you stop giving the patient drugs that can't do them any good, and you stop giving them drugs that cause interactions, and you get them on drugs that are more amenable to them. And there was a study done in 22 where this test was used on 30,000 Medicare Advantage recipients in Kentucky. 5,000 of them had the pharmacogenetic profile. In the 5,000 that had it, relative to the 25,000 that didn't have it, the ones that had it, their average healthcare spend per year per enrollee dropped by $2,625. If you do that math out to the entire Medicare population, if everybody had pharmacogenetic profiling, we would save $171 billion a year in the US using that tool. So the answers are there.
Yeah.
Primary care cannot do it alone. We've got to use specialty services that are readily available and that can prove that they do it better and integrate those in and make those services available. By the math that we've been using, the data currently shows that we ought to be able to deliver way better health outcomes than we're currently delivering for about 45% of the money.
Hey, Brian, I couldn't help pick up your comment about the ruck because one of my colleagues, orthoplasty colleagues for many years, 20 years, sat on the ruck. And each year he would give a talk at our annual meeting, the Academy meeting, and he would say how well we did. And we get a round of applause. But I have a lot of friends that are primary care docs. And I think I told you I was a PCP way back when. I always say to myself, well, no wonder why the primary care docs hate us, right? No wonder there's a cultural rift because their guy has to go back and tell their room of primary care docs that the orthopedic docs just got 5% more. And that's part of the problem, that we've got that zero-sum mentality. I remember that Porter and Kaplan talked about there's so much to go around if it's done right, right?
Right.
The other thing I want to thought before we throw the retail giants under the bus, because I've been thinking a lot about this. You think about 2006, 2007, and Lowe's was the first one to step up with centers of excellence with the Cleveland Clinic for Hearts, and then it was joints. And actually, John, we got involved with NOSA, if you remember.
Yeah, I do.
We were an equity partner in NOSA, and Walmart got involved. But they weren't standing up these practices, right? They were counting on people like Ruth Coleman to guide them to the best quality. And they were hugely successful, and it still is 20 years later. But I think they had a little mission creep when they thought because they could sell diapers, as you said, that people would trust them. I think that's a key piece that may have been missing, that they go into Walmart and they buy all their stuff, that they're going to trust their doctors, their providers, right? That may have been a missing link to underestimate the importance of trust in that relationship.
Yeah.
Yeah, that has to be part of the equation, because trust is the core foundation of how medicine works, I think.
And even from the clinician perspective, trusting Walmart to be your boss. But, if you look at Walmart and Walgreens and Dollar General and so forth, the one of these that's actually working is the Amazon One Medical, right? Because they acquired a high quality primary care practice. They didn't stand up a transactional primary care clinic, right? I mean, One Medical is doing reasonably well with Amazon.
But the real success came from Iora.
Yeah, oh yeah.
Right. That was more Medicare Advantage patients, right?
Chronic.
Right.
Yeah.
And
Chronic disease.
And that was developed by Ruchika Fernandopoul. Whenever I think of Ruchika, who's a good friend, I think, if I have to know somebody who's got $800 million, I just assume it'd be Ruchika. But yeah, they were very forward thinking. They were very aggressive, heavy use of lay coaches to build trust, and they got results. They were terrific. I think that One Medical has had a relatively small group of employers that it was working with, but it had a large group of individuals who would drop in and who had individual accounts with them. I think that Amazon is still trying to figure out what its model is going to be. They started off with PillPack, and I think that they're still going to be involved with the drug market, but they haven't really shown a cohesive strategy yet.
I think your point, I think for Amazon, since they've clearly mastered the acquisition and distribution of product, and the pharmacy space, we all can agree is about as opaque from a price cost point of view as any other business. It seems like that's a huge opportunity for them if they find the right partner to intervene on that. But Brian, we were at a conference together recently. We met the folks from South Central Foundation, which I know you know from NUCA, the NUCA Health Plan in Alaska, which is kind of like, I think you've said, and I think others have said, it's really the best healthcare probably in the world, but certainly in America. And certainly countries like Germany, which are probably the closest to us with how they pay for healthcare, we're twice as expensive as they are, and their outcomes, to your point, are better than us. I don't think it's that crazy to make the comment you made, which is, we could probably deliver better care at almost half the cost. I mean, because others have done it. It's not that unique. But I want to just ask you about primary care, because you said one of the key roles of primary care is, prevention. And I still argue that we have not taught folks in medical school in this country about prevention of chronic disease. We typically teach diagnosis and treatment, diagnosis, treatment, diagnosis, treatment. And, when you think of prevention, it's a longer term point of view. And let me just connect the dots on my question here. Is part of the problem with the retailers, these are all, obviously for-profit companies, they have shareholders, and they're so used to quarterly earnings, annual reports. When you think of long-term care, prevention of, let's take the classic diabetes, especially type 2 diabetes, which are now most patients in the country with diabetes have type 2, not type 1. When Steve and I were in medical school, it was 50-50. Now it's like 90-10, right? You could prevent 100% of type 2 diabetes. You could 100% with, the right education, training, diet modification, exercise, and some combination of all that. Maybe maybe some ancillary drugs now when you're pre-diabetes. But that's not what we're taught in school. We're not taught about how to prevent those things. And, to your point, we even have a problem with so-called therapeutic inertia when we see a patient with hypertension who's on medication and still has hypertension. We say, come back next year. We don't adjust the medications, to your point. So there's a huge opportunity there. So my point is, my question is part of the problem with the retailers getting into space that they're just not measuring the right outcome, or they're not measuring it over enough of a period of time?
I think to your point, all the incentives are in the wrong direction. And you can see that in how they staff their clinics. Staffing the clinic with a nurse practitioner is a real different thing than staffing it with a lead physician. Physicians have way more training. They don't refer as often as nurse practitioners do. There are all kinds of advantages. A lot of that has to do with the bottom line. Nurses are cheaper, and in the main, they're just as good as doctors, until you have somebody that really needs a doctor. I think that there is no such thing in healthcare as healthcare light. A medical facility that is open to the public is going to get the full range of the human experience coming through its doors. In a lot of cases, like a hospital ED needs to be prepared for pretty much anything. And while I don't think that holds exactly for a primary care facility, there's a certain level of competence in all things that it does need to have, and you can't really do that on the cheap. You also can't do it if your visit times are too short. The visit time for primary care at Johns Hopkins right now, the last time I heard, was about 7.5 minutes for a visit. A 20-minute office visit really gives you the time to schmooze, know the patient, think about the problem, and you get better results, and you refer a lot less often. I remember that when I was running the clinic company that I was involved in, if you looked at any group, they would typically refer 25 to 35% of the population of that group to a specialist or a facility during the course of a year. We were at like 7%, 8%. And that was because the primary care docs had the time to do the things that they had been trained how to do, but in an ordinary environment, were not allowed to do because they were being pushed to get the patients down into the specialties. I think all of these they're part and parcel of the core problem that you're identifying, which is that the incentives are wrong. And using a traditional business model for healthcare that is profit seeking, at the end of the day, it can't work. And that's one of the problems that we're really faced with in trying to change American healthcare, is dealing with, for example, the Optums of the world that now have more than 90,000 active American physicians are employed by Optum. And they are a profit-seeking organization first and foremost. And the price of that comes in terms of unnecessary and exorbitantly priced and often poor healthcare delivery. So to your point, we could do it a lot better, but we've got to have the incentives aligned. There's no way around that.
Well, Brian, this has been an interesting and exciting conversation, and maybe this is a good time to ask you to put your thinking hat on and blue sky thinking. And you've been in this industry for 40 years, a scholar, a thought leader, healthcare leader. What do you think is going to happen in the next 3 to 5 years? And we've heard for 10 years it's not sustainable. Is it still not sustainable? And what's going to happen in the next 3 to 5 years? What are your predictions?
I think that, there's a guy in Chicago named Michael Millinson who wrote the book in 1997, I think, that was called Demanding Medical Excellence. It was the book that sort of set off the quality and the safety movement. He wrote an article after Crossing the Quality Chasm had been out for 10 years or something, and he says, nobody's done anything. Nothing's changed. I think the name of the article was The Great American Healthcare Collapse. What's taking so long?
Yeah.
I think that the biggest mystery of my professional career has been, why have the employers, with all of their clout, not come together in a way that says, we're not going to do it this way anymore? And I think that in large measure, they have been divided and conquered by the healthcare interests that have come and taken over the business health coalitions by giving them money so that they don't have to pay dues. And so nobody wants to piss off the drug companies that are giving them a lot of money in the business health coalition, so they don't do anything controversial. I think what we need to do is tie together the business community, the mid-sized groups, as well as the jumbo groups with data. Everybody needs to be able to see it, see what everybody else's data is, de-identified, and use that data to come together and together get better deals on buying healthcare services and understanding what the vendors each represent. I mean, right now, for you to get business, you have to either go to an employer at a time, or sometimes you can go to a group, but you're going through a bunch of intermediaries who may or may not want you for a whole bunch of reasons that have nothing to do with your level of performance. We have to have a way to say, okay, your population has these things good about it and these things that it's weak on, and here's what you're spending on your musculoskeletal in your population. But if you used vendor A here, which happens to be upswing, real world data shows that you would end up paying this with these outcomes. That kind of information is not yet readily available, and it could be. And I think there'll be a drive to change it in the next 3 to 5 years.
You've hit on the themes that it took us a while, I think, Steve and I, to figure out. It's all about the employers at the end of the day. And I think also I would add the employees, Brian. I think now we're, especially unions, actually, because they're kind of organized in the first place, because you got to be together, right, in the same room talking about this. I think the employees are starting to figure it out, hence the litigation, Johnson Johnson, and now Wells Fargo, and you've seen the successes of unions like 32BJ in the tri-state area, how successful they've been once they get together and say, listen, we got to take some control over this, because they're the ones who are getting, I don't want to use the word screwed, but they're the ones who, I'm sure these companies would rather invest in their employees, frankly, in the form of higher salaries than paying higher healthcare costs. I think I saw something recently that unions figured out that for every dollar they negotiate in quote unquote increases, about 40 cents of the dollar is going towards health benefits. So it's not really coming directly to the employee. So don't you think they're going to play an important role in this? Since they're the ones, ultimately, they're the payers, right? The employees and their employers are the ones paying for all this.
No, I think you're exactly right. And I think anybody who has a conversation with Cora Upsall, who's at 32BJ, will see how ferocious she is about these issues exactly.
There's so much, the problem is it's so freaking much opportunity. And I think, Steve alluded to that. It's like, where do you begin? Do I start with MSK? Do I start with pharmacy? Do I start with the variability in hospitals? Do I manage chronic disease better? It's like, it doesn't matter. It just freaking starts somewhere.
Starts with the data, right? As Cora said, starts with the data, look at the data, go, whoa, I had no idea.
Well, Brian, I think we're running out of time for today, but I have to, first of all, thank you for your years and years of effort towards this space, and God bless you for the perseverance, because I think for a lot of people it get pretty frustrated, and we've all been hoping and dreaming there'd be change coming, and you've been hoping and dreaming it for a longer time than I even knew about this business. Thank you so much. And for any of our listeners who are not part of Healthcare Hackers, I would urge you all to join. It's a free listserv.
Oh, yeah.
Brian not only created it, but, modulates it, and there's great information on there. And it's just the key is just keeping up with all the info, because it's such a great, august group of healthcare leaders. And it's a diverse group. It's benefits folks, it's attorneys, it's employers. It's quite an august group. And I'm sure you're proud of how it's grown over the years, Brian. But I want to just, on behalf of Steve and Lisa, I want to thank you so much for joining us today, and let's keep up the good fight. I used to say I'll believe it when I see it, but I think I'm actually starting to see it. I think it's starting to happen, and you always give us a little bit of optimism. So thank you so much, and appreciate it.
Thanks, Brian. Really appreciate it.
The pleasure is mine. And what you've got is a great organization. I mean, it's the model. Everybody in the country ought to be putting together chapters based on what you're doing, or you become the hub. But what you're doing is beyond estimation in terms of saying, here's what we're realistically capable of right now. Because I think that most people don't believe that it exists, and it does. So it's thrilling to see what you're doing.
Right.
I'm very appreciative. Thank you for having me on.
We want to take a minute now to introduce the new MTVA membership program. As a 501c3 nonprofit, we rely on support from our grassroots network to advance our mission of creating a value-based health system with high-quality patient outcomes at a reasonable cost. As we continue to grow and broaden our impact, we're excited to invite like-minded organizations and individuals to join our membership program. We're proud to offer two membership models, Ally Member and Trade Member. Tax-deductible membership contributions help us enrich the healthcare environment with quality content, including this podcast, and robust platforms to fuel discussion, collaboration, and advocacy that lead to groundbreaking solutions. For more information, including a full list of benefits offered, visit our website at www.movingtovalue.org/trade-member. The link is also in the episode description. Thanks again for listening and for being part of this important movement.